Hello. Today we're going to be talking about ICD-10 Documentation Education for Clinicians, and our topic is mental and behavioral disorders. Thank you so much for joining me today. I'm Susan Carmichael, and I'm the Chief Compliance Officer for Select Data. I am a certified psych nurse and have a lot of interest. I did psychotherapy for a number of years, so I was very interested in seeing some of the changes that CMS has made this year with the ICD-10 coding changes that are coming to your neighborhood and mine. One of the first things we always let you know is our disclaimer regarding the fact that this information that we're presenting should not be considered legal advice. It is for educational purposes only. If there's any questions regarding legalities, you should by all means confer with your corporate counsel. The objectives of this session 5 is essentially to look at the focus on the importance on good documentation and the essential need for that for mental and behavioral health disorders. Specificity, as we've been stressing in every single session, is required now more than ever, and we're going to be identifying specifics that are needed for many diagnoses, including a very common diagnosis that we see termed depression. Now, what is it that ICD-10 requires for success? Well, the answer is obviously you, and we want to say thank you for each and every clinician who's taking the time to get properly prepared for the documentation that's going to be necessary for ICD-10, which starts now, no delays in sight, starts now 10/1/2015 with that first claim submitted. But it does mean that we're going to be dual coding beginning that August 3rd episode for home health. So welcome to the world of ICD-10. Now, for mental health and behavioral disorders, an area that's very meaningful to me, 1 in 5 Americans will experience a mental disorder this year. And we all know people, I'm sure, who have some type of mental health or behavioral disorder. Mental health professionals are also dealing, besides the changes in ICD-10, they're dealing with the DSM-5. So both the DSM and the ICD codes are used in diagnosing mental health patients by psychologists and psychiatrists. And for 9, they actually had the same codes, not so for 10. So this particular segment of the healthcare community is really working diligently to try to get 10 and the DSM more in alignment. Now, according to Leanne Renz, after interviews with several mental health leaders, ICD-10 is considered one of the biggest deals in the mental health community. A recent survey showed that it's the 3rd most important IT initiative for this year, falling behind the adoption of the electronic health systems and PHI security, because as you know, no one has more HIPAA concerns and controls than the mental health system. The DSM-5 was released in 2013. It replaced the 4, and there is a concern that it wouldn't be aligned properly with 10, and of course they were working towards that last year when ICD-10 was then delayed, and there was significant discussion that there wouldn't be 10, that they were going to move to 11. Well, I think everyone took a look at the fact that ICD-10 was released in 1998, and nearly 20 years later we're still talking about whether or bringing it on board, and no one wanted to wait another 20 years to bring on ICD-11. So this is why they've been working feverishly now to get the DSM-5 and the ICD-10 codes more in alignment. The ICD-10 and the DSM-5 are described as being companion publications. So when you're talking with psychiatrists about your patients who have mental health problems, the DSM-5 is going to provide the most accurate and updated criterion for diagnosing mental health disorders, and it makes a common language for all clinicians to communicate about their patients. 10 contains the code numbers found in 5 to ensure proper insurance reimbursement. Now, while 9 had been harmonized, as I've shared with you, 10 has not been harmonized yet with DSM-5. Don't you love the term now, harmonized? It's being used by CMS. We have harmonized the OASIS C1 with other tools, assessment tools used in various levels of home health, and now we're working to harmonize the ICD-10 codes with the DSM-5. There's everyone's acknowledging that there have been significant advantages to greater detail in documentation, such as nicotine dependence. That's been updated to identify specific tobacco products such as cigarettes, chewing tobacco, and other tobacco. So as you can see, mental health professionals, your psych team is frequently working with 2 classification systems, one in which they'll do the narrative diagnostic statement for both the DSM as well as for usually that statement will allow us then to put in the proper code for that diagnosis. So the DSM-4 provided the diagnostic codes solely for mental disorders, whereas 10 has codes for both physical and mental health disorders. So they're being woven into the DSM-5 right now. Now, the devil's in the details, as I say. It becomes crucial to be very detailed as to specific symptoms noted and the time when they occurred. Not just the date, but the actual time of that date. It's important to note behaviors, time of occurrence, and any specific triggers for that behavior. It's also important to note onset of behaviors and trends or the patterns that are noted. Now, the adult block of mental health codes, the F60 through 69, contains new disorders including pathological gambling, fire setting, and stealing. We didn't have those before. Not that we didn't have the problems seen before, but we didn't have the clear-cut way of identifying a code for the specific disorder. I also wanted to make everyone aware that there is a new role in the healthcare community, not just for mental health, but this is where I've seen this clinical documentation improvement specialist. I've seen them with the psychiatrists and psychologists regarding improving their documentation. But now in many hospitals, the clinical documentation improvement specialist is there to assist physicians with improving their documentation. And yes, there is a certification for this specialty. ACOs are now actively employing this CDIS to assist physicians and scrutinize record documentation. So please be aware, this is a specialist nurse who is reviewing the documentation for physicians, and now ACOs are having them expand that to reviewing documentation for records in general. This CCDS or CDIS, there's 2 different credentials. They are looking at very specific specialized disciplines. They have an in-depth understanding of anatomy, physiology, pathophysiology, and pharmacology, a knowledge of office medical coding guidelines, CMS and private payer regulations, inpatient prospective payment system, and they're moving to home health, expanding that role also. This certified clinical documentation credential has been created to provide a mark of distinction for this very unique profession, and I am meeting with one of these individuals who possesses this credential in Florida next week, so I'm really curious to talk with her more about the certifying exam and what she did to prepare for that examination. Now, the level of specificity of the documentation required in inpatient setting is very detailed, and thus so too in home health. But a big difference here, we are not using the 80,000 procedure codes that are seen in inpatient. So again, this was another reason for this new credentialed specialist. As in ICD-9, the codes for mental health and behavioral disorders are located in Chapter 5 of ICD-10. However, in ICD-10, the clinical terminology and classification of many of the conditions have changed. There are now more subchapters, a greater number of categories, subcategories, and codes that's going to give a greater clinical detail of the patient's condition. So let me give you an example of that. Poor sleep patterns won't cut it with ICD-10. In order to make that statement, it would be expected that the clinician will document when the patient is sleeping, when they're going to sleep. Do they have a routine time that they go to bed at night and awaken in the morning? How long are they sleeping? What length of time? When are they awaking? Is the sleep interrupted for any activity or event? How does the patient describe the level and the quality of the sleep? And what have they done to mitigate any poor sleep patterns and to improve the quality of their slumber? Pain disorder changes. There's now a distinctive code assignment when pain is exclusively related or indirectly related to psychological factors. So F45.41, pain disorders exclusively related to psych factors, or F45.42, pain disorder with related psychological factors. So we're even splitting there. One is related to, and the other is related with. Now, with depression, there was one notable change in the coding of mental disorders for ICD-10, and it was for depression. This is a new code for unspecified depression, a major depressive disorder, single episode, unspecified. Like other mental disorders, the documentation of depression must come from the physician. Even if the person has you've completed the PHQ-2 and they've scored a 3+, does not mean that they can have the diagnosis depressed. It could very well be that during that period of time, in answering the questions, there may have been a period of time where they weren't feeling their usual self, they were down. But to label them with a clinical diagnosis of clinical depression is inappropriate. And also, we cannot, as clinicians, as nurses, create medical diagnosis for patients. We can create a nursing diagnosis, but not a medical diagnosis. Now, M2250D, if answered appropriately, would reflect if the patient was under active treatment or if they had had a positive response when screened for depression. So do you have interventions documented in your plan of care? If you answered yes to M2250, you better have your documentation of your interventions clearly delineated. So again, the diagnoses that are actively being treated should have an active plan of care. We should see orders and goals for those diagnoses. Now, Dr. Benjamin Miller of the Colorado School of Medicine has noted that in typical depressive episodes of all three varieties, whether it be F32.0 mild or F32.1 moderate or F32.3 severe, the individual usually presents depressed mood, a loss of interest and expression of joy, reduced energy, some increased lethargy, and decreased activity. Dr. Miller, who of course is one of the consultants for CMS, states we can expect to see other symptoms such as decreased concentration, poor attention span, decreased self-esteem and self-confidence, ideations of guilt and unworthiness, pessimistic views of the future, ideas of self-harm, disturbed sleep patterns, and decreased appetite. Now, when we're looking at completing a validated tool, and most organizations are using the PHQ-2. Please note, CMS does not mandate that a home health agency use that tool, but they do have a question that says, have you used a standardized validated tool? So of course, if you write no and your patient has depression and later there would be harm to them, you're not meeting, of course, the best interest of the patient. So CMS is really encouraging organizations to use best practices, and that would call for a validated, standardized tool. Now, the number of new concepts for ICD-10 is not new, but the focus of the documentation is good patient care, and patients deserve to have accurate and complete documentation. So if indeed you're using the PHQ-2 in your organization and the patient would score a 3+, there should be some protocols that are in place that identify what the clinician should do next. You can't walk out of the room with a patient who appears severely depressed and then leave the patient there and say, oh, we'll be sending another nurse to see you. Most organizations have a protocol in place. Now, it may be that they ask the clinician, they've educated everyone on how to use, let's say, the Beck suicide ideation scale, or they have other tools that they want to use. And you need to know what is the next step if indeed there is a score of 3+. Now, for anxiety and depression, conditions such as anxiety F41.0 through F41.9 and depression NOS F32.9 will be coded if the POC is impacted. The clinician must document symptoms of anxiety clearly, specifically how is the anxiety manifested. And there are new concepts supported by ICD-10 per the National Council for Behavioral Health. And these are really important to know. They have made a clear delineation between use, abuse, and dependence, and it's about time. For many years, and I had headed, was an administrator of a mental health substance abuse program in Ohio for a few years. And it used to just bother the heck out of me when people would just use use and abuse and dependence interchangeably, when for many professionals, they are distinctly different. And finally, we have ICD-10, which will clearly identify that. They also identified new concepts for bipolar 2. Yes, bipolar 2, for those of you who are not psych nurses, everything is not just bipolar. Bipolar 1 and bipolar 2. Also, mood disorders related to physiological conditions, as well as adjustment insomnia. So let's talk about use, abuse, and dependence. To reflect more current terminology and to standardize the terms and to stop the incongruency of using these terms interchangeably, ICD-10 makes it very clear that they are no longer interchangeable. So alcohol dependence, drug dependence, and non-dependent abuse of drugs are classified in 3 separate categories and increased combinations. So if we had use, it would, let's say we were saying it was 291.5 in ICD-9, alcohol-induced psychotic disorder with delusions. That would now equate to an unspecified alcohol-induced psychotic disorder with delusions, so very specific. Whereas abuse, which was the same definition in the same code, is now split out alcohol abuse with alcohol-induced psychotic disorder. And then dependence is split out even further. And for opioid use, abuse, and dependence, again, we have opioid withdrawal with withdrawal. We have abuse uncomplicated. We have dependence uncomplicated. Manifestations would include if indeed there is abuse with hallucinations and an induced psychotic disorder. If it's opioid dependence with opioid-induced sleep disorder, or unspecified with intoxication, delirium. Now remember, the 7th character in the ICD-10 coding will be the extender, And that seventh character for the mental health areas would identify the episode of care as initial, subsequent, or sequela, any complications or conditions arising as a result of that specific condition. Now, again, something that's new, poisoning by adverse effect of an underdosing of other psychotropic drugs, intentional self-harm, initial encounter, or subsequent encounter. If it was initial, of course, it's going to have the A after it as the extender. But it's about time that we're beginning to get codes that clearly identify when there's underdosing of a use of certain medications. And it is not uncommon to hear in the mental health world where you have a patient who may be depressed or may have anxiety, and they deliberately choose to lower their medication for a number of reasons. It may be that they don't want to look in the mirror and say, oh, I have this problem, and by virtue of taking the medication, it clearly states you must have a problem. Sometimes they do it because their feeling is if they don't take a med to control it, maybe they will harm themselves. So we need to identify what is the reason, but if they are intentionally underdosing, we now have a code for that. And again, if we're using that code, we have to know what the reason is for the underdose. Now, a psychoactive substance use, abuse, and dependence, when the documentation refers to use, abuse, dependence of the same substance, the most severe one will be utilized. And when you say use, abuse, and dependence, dependence would be the most severe one. So these would be assigned to identify the pattern using the following hierarchy. If both use and abuse are documented, and a person could be a user and an abuser, then we're assigning only one code for the abuse. If both abuse and dependence are documented, we're assigning a code for dependence. If use, abuse, and dependence are all documented, we're assigning a code for dependence. And again, if it's use and dependence, it's got to be dependence. Now, there weren't as many significant changes on documentation and coding of mental health and behavioral disorders for ICD-10 as perhaps in some of the other categories, but the importance of accurate documentation remains just as high. So again, as always, before any type of code could be used for substance use, abuse, or dependence, it would have to be confirmed by the physician. Now, Code First Guideline, ICD-10 has a coding convention requiring the underlying or the causal condition to be sequenced first, followed by the manifested condition. And this is referred to as the Code First Guideline. Nothing really new here, but please be aware if the patient is on an antidepressant drug such as triptanol, or if the drug, and this caused the patient's weight gain, then it's considered an adverse effect, and this would be the one of the causal conditions of the patient's obesity. Therefore, we would have to have a diagnostic code of T43.015 used, an adverse effect of tricyclic antidepressant first. So as you can see, the drug causing the weight gain would need to be documented for that required specificity. If it's not, a claim can be rejected because we don't have the reason for that clearly delineated. Now, in borderline diagnosis, we see that at a hospital discharge, the diagnosis is coded as confirmed unless the classification provides special entry. And since borderline conditions are not uncertain diagnosis, no distinctions made between the care setting. So let's look at bipolar 2, because you may see this and not be as aware of it, because bipolar 2 disorder is frequently misdiagnosed. Now, bipolar disorder is characterized by one or many manic episodes and one or more depressive episodes. Bipolar 2 is diagnosed after one or more manic depressive episodes and at least one hypomania. And the highs in bipolar 2 are called hypomanias, and they're not as high as those in bipolar 1, those true manias where the person is just thinking and moving at an unbelievable quick fashion. Bipolar 2 is harder to diagnose and usually is misdiagnosed because frequently the hypomanic episodes do go unrecognized. People usually seek help for the individual when they're in the depressed state. When they're in this somewhat high hypomania state, frequently family members are happy to see them moving around and doing things, and so they don't bring them to the physician to see that this is a more manic state than what would be normal for them. We need to make certain that we're very careful in documentation. So we need to know, has the person had recurring depressions? How long did they last? When did they return? How frequently have they been in the last year? Has the person had periods lasting 4+ days when they were feeling abnormally self-confident or social, the I can do anything kind of belief and feeling? Or that they required far, far less sleep than usual? I only need an hour and a half now and I'm just feeling great. The unusually talkative or very hyper individual who just can't seem to speak very slowly at all but has to speak at a very rapid pace. Or the individual who's very irritable or quick to become angry, more easily distracted, thinking faster than usual, but it's usually not as quick as you see with a person who's going through a significant manic state. Now, just some history. Hippocrates was the first to actually attribute a psychological problem to a physiological issue. So it's astounding to me today when I hear people feel, oh, really? It's all in their head. There are frequent diseases that are physiological in nature that can cause a psychological issue. It's thought today that mental health, mood disorders actually affect 5% of the world. 70% of the world's population will have more than one episode. It's 2 to 3 times more prevalent in women than men and occurs actively in young children as well as the elderly. And so frequently we don't think of it really impacting young children, but it certainly can. Have this mental anguish, maybe feeling significant stress, and stress increases the levels of cortisol. That's why ongoing continued stress is not good for your heart. It's not good for the body overall. That cortisol should not be naturally at the levels that stress can bring it to. So this is something that should be taken a look at, and it can be disrupted by our circadian rhythms. Now, ICD-10 is also looking at adjustment insomnia, and this is acute insomnia that occurs for a short period of time, usually lasts no more than a couple of months and can be just a few days. It's routinely brought on by that stress that's increasing that cortisol, or some type of anxiety or depression. The onset of the adjustment insomnia is quick, and it coincides usually with something that's occurred that's very important in the person's life. And it can just as easily be a death in the family, some kind of issue that's occurred in the family, losses of jobs, losses of homes. We saw a fair amount of adjustment insomnia during the big bubble burst with people losing their homes. This could bring on adjustment insomnia as people were trying diligently to figure out ways to save their lifestyle. People should note their patterns of insomnia. For this adjustment insomnia, we need to know, again, what are the sleep patterns? Are they routinely going to sleep? And if they say, I used to have a regular time I went to bed, but no more, what changed? And that's when you usually get to the root of what's causing some of this. The patients may wish to keep a log. Also, you want to note, are they eating or drinking something before bedtime, usually the 3 to 4 hours before? Ascertain if the sleep times are regular and their activities, and of course, you want to know what their stress levels and stress reduction methods that are being employed. Now, we see a lot of dementia in care of our patients, no matter what level of care we're treating our patients. In home health, this is a very common diagnosis, and it's commonly seen now as one of the reasons for rehospitalization. So dementia and depression are two areas that we're really hone in on in home health so that we can help with depression, not to have that person readmitted, and with dementia, not to cause a situation that would trigger a rehospitalization. So what type of dementia? And here's where we really have to know. It's not good enough to just say they have dementia. Is it dementia that is related to Alzheimer's if they have Alzheimer's? And we can no longer assume, we cannot assume that the dementia is a result of the Alzheimer's. ICD-10 will not allow us to make a causal effect decision. So if they have dementia and they have Alzheimer's, the doctor has to confirm they're linked. Again, vascular dementia, frontotemporal dementia, dementia with Lewy bodies. If they have Parkinson's, again, here's a very common one where people say, oh, they have dementia and they have Parkinson's. Parkinson's must be commonly causing it, not necessarily. And the physician must note that. Now, so we have to know the type. The doctor has to note if it is causal to another disease that we're also coding. Are there any behavioral disturbances such as agitation or hallucination? And were these documented by the physician? Does he concur? If the patient wanders, when have they done that? What has the family done to mitigate it and reduce risk? And does the plan of care indicate that your teaching was directed at the caregiver due to the patient's dementia? I can't tell you how many times we audit records. Patients got significant dementia, and the clinician is identifying that they're teaching them let's say the new med change or a dressing change. It's certainly fine to indicate for the patient's ego strength, involve them, but we've got to make certain also that a caregiver is involved there too. And have you answered M 1700 to 1750 appropriately to reflect the mental status and the impact on learning? If you have any questions at all, I urge you to give me a call. I have my office number there on the slide, 714-524-2500, extension 235. Or email me at susan.carmichael@selectdata.com. Thank you so much for joining us today.